period. All these things can be, answered maybe in this webinar. So we look forward to active discussions after what Dr. Amrita is going to share with us with this article, which she found was a good article. So let's go ahead.
Yes. So good evening, everyone. I hope my screen share is visible to everybody.
Yeah.
Yeah. So this is a review article about the cataract surgery in uveitis. So this basically covers some of the couple of things we should all be looking for in our cases whenever, and then we should look into different types of uveitis that we are dealing with. So each and every uveitis, I think retina people will be more well versed with this, that every uveitis that we are dealing with has a little other prerequisites than the usual. So being cataract surgeons with the retina department, we can come up with better post-operative outcomes for our uveitic cases. So yeah, so just a basic introduction. Cataract surgery in uveitic cases has been found to be very challenging. And cataract in uveitis mostly results because of two things. It may be because of the intraocular inflammations that the eye has, and also from the chronic use of the corticosteroids. The incidence of uveitis varies from 57% to up to 78%. And these present with very unforeseen intraoperative complications that may be found only while operating a case. And but presently, with a lot of developments that have happened, so the outcomes have been maximized because we have a better understanding of the disease. We have these immunosuppressants that we can like use along with them, and they can be minimally invasive surgical techniques that we are using with more biocompatible intraocular lenses and more trained surgeons, and we are anticipating some post-operative complications, so we can always keep a watch for them. So for a successful surgery, we should have educated patient selection with a careful surgical technique and aggressive pre-operative and post-operative control of inflammation. So basically, we're dealing first with cataract extraction in different uveitic entities. So cataract, just one second. So cataract surgery in patients with Fuchs uveitis. So this is the most common thing. I'm sorry, I think my one slide. Yeah. So this is cataract surgery in patients with Fuchs uveitis. So in this, we've seen this is the most common entity that we encounter in our clinics. So in this, there's a low-grade and chronic uveitis that appears with very rarely we encounter any posterior synechiae. Patient presents to us with blurring of vision, which is mainly due to cataract formation and also the vitreous floaters. The incidence of cataract is as high as 75% in such cases, and the possible complications post-cataract surgery can be hyphema, progressive vitreous opacifications, glaucoma, a spontaneously resolving vitreous hemorrhage, and with a permanent elevation of IOP. Rarely we can encounter retinal detachments and extensive synechiae formation with corneal edema. Mostly these patients end up achieving a good visual acuity post-operatively, but there's always a chance for a vitreous haze, which is one of the major causes of decreased post-operative visual acuity, which is less than 20/20 we encounter. So this is cataract surgery in patients with juvenile idiopathic iridocyclitis. So in this, the patients that present to us is a chronic non-granulomatous anterior segment inflammation, and mostly these kids that come to us are in the amblyogenic age. So we can't really wait too much for these patients because of the possibility of amblyopia. So the complications that we have is cataract with a band keratopathy with extensive posterior synechiae, hypotonia, or glaucoma. Because of the intensive use of preoperative and postoperative corticosteroids, we can have with us the systemic and the topical steroids with the periocular steroids, which we have to use in the perioperative period for maintaining the anti-inflammatory property. And the surgery should be delayed until the anterior chamber is exactly free of the inflammatory cells. The flare will persist, but the inflammatory cells should not. And also a couple of studies do mention about the limited vitrectomy along with a combination of the lens removal. The heparin surface modified IOLs have been used in such cases. So initially, previously, it was said to be mentioned that whenever there's a case of GIA, we are not implanting the IOL right away. But with the advancements of all the technologies and other IOLs that we have, so the complications such as reformation of the posterior synechiae and development of membranes over IOL, along with the cocooning of the IOL, malignant glaucoma, hypertony, and phthisis. So these were very common previously, but right now they've quite reduced. So the main objective and the take home for the JIA case is we have to have an adequate immunosuppression, and we have to aim at a zero tolerance for inflammation in the anterior chamber whenever we are planning on operating such cases. So we have to aim at abolishing every inflammatory cell in the anterior chamber so that we can have a better post-operative outcomes. So these are cataracts. I think actually I'm having this problem. Yeah, so in this is another situation in Behçet's disease, so in which we have to see that the cataract incidence is almost 36% in such cases, and the eye has to be free of inflammation for a minimum period of 3 months. So we always have to understand that we will need a systemic and a topical steroid cover in such cases. So prophylactically, which have to be started 1 week preoperatively, continued post-operatively, along with the immunosuppressive drugs to be continued along with that. Cataract surgery in other forms of uveitis. So these were the cases that we have encountered by the immunosuppression and everything. And these are the other forms of uveitis which can be dealt of as one entity that we find out. Like in case of sarcoidosis, toxoplasmosis, Behçet syndromes, sympathetic ophthalmitis, and any other type of uveitis. So the baseline, we still have to remember that the absence of inflammation should persist up from 2 to 3 months before the surgery. Currently, the guidelines for management of uveitic cataract.
Dr. Amrita, can I interrupt you? I
Yes,
think
sir, sorry.
you missed one slide. There was one on intermediate uveitis.
I think, yes, I think my slide were not moving. This one. Yes, sir. So this is particular case in which we're looking at intermediate uveitis. So the inflammation is primarily limited to the posterior segment. So the synechiae seldom develop and the incidence of glaucoma remains low in such cases. But still we have most common cause of the poor visual acuity in these cases post-operatively because of the CME, submacular fibrosis, and epiretinal membrane formation. Yeah, so coming to the current guidelines for the management of the uveitic cataracts. So it is very important that whenever we see a uveitic cataract, we are supposed to clinically evaluate it. Now, it should be a lot more meticulous than the regular cataracts that we are operating. So the clinical evaluation, we should have very realistic expectation about what specific diagnosis of the uveitis we are dealing with. So just as we discussed that every type of uveitis might have a little difference in the management preoperatively, intraoperatively, and postoperatively. So that is how it is important for us to classify what type of uveitis are we actually dealing with. Also, it is very important to find out that to determine what is the visual potential of the eye before planning the cataract surgery. So we should give patient all these realistic expectations, and we've come across in multiple studies, they have found out that acute uveitic syndromes are associated with better outcomes as respect to the chronic uveitis. And always the macula and the optic nerve should be thoroughly examined so that we have a visual potential to be known for that particular eye. Then eyes which have a chronic retinal complications, such eyes should be left as per to the discretion of the surgeon to operate, whether the surgeon wants to operate these eye under the nil visual prognosis or for cosmetic reasons. But again, so one entity that I really want to highlight upon is phacoantigenic uveitis. And this is a definite indication for a cataract removal in an eye that is not blind. So the control of the preoperative inflammation. So this reduces the risk of the postoperative CME, and the steroid prophylaxis has to be administered. So it is really important in two mainly cases in which we are suspecting a recurrence of uveitis following a cataract surgery, and also in case of infective uveitis, wherever there's a chances that the uveitis is going to recur post-operatively. So again, we have to taper along with the oral steroids with the periocular steroid injections. And also we can take the help of the topical NSAIDs along with the intravitreal injection of a preservative-free triamcinolone acetonide. The complications, so the complications that we are dealing with when we have to see is that if we're dealing with a low intraocular pressure, which is 6 mmHg or less, in cases when we can preoperatively find that we have a seclusive pupillae that we are dealing with apparent phacodonosis, and also on B-scan ultrasound, if we are able to look at that there's a presence of a choroidal effusion or any diffusely thickened choroid. The diagnostic age, so like a routine cataract surgery, but we have to be a step up from whatever diagnosis we are doing for a routine surgery. So in such cases, we have to assess the macular, optic nerve, and the retinal function separately. We have to make sure that we're looking at pupillary response, giving us a guide about the dilatation. And if we can in person try to check about the light projection rays. And also in cases where color perception is possible, a B-scan ultrasound should be done, and the patient should be evaluated for OCT and FFA if possible. The macular potential test should be done using the laser interferometry, and the laser flare meter will help us find out if there's any flare or reaction into the anterior chamber. So coming to the optimal time for the cataract surgery, so as I mentioned, most of these classification of uveitis give us a point that quiescence should be maintained for at least 3 months. And if there's a intumescent cataract that we are dealing with and we have to operate for the patient right away, so we have to make sure that we give an intravenous methylprednisolone 1 gram 1 day before the surgery. And for Behçet's disease, the inactivity should minimum be at least for 6 months. The counseling, which is very important in such cases, so that we explain the patient what is the visual prognosis and the general risks that are involved with the surgery. And we have to tell the patient what is the minimum quiescence that we are looking at, so that when the patient comes to us, he or she can actually tell us what was the last time when the eye was having symptoms of any inflammation. And surgery has to be a complicated one and not like a regular one. So it has to be explained to the patient that it might take longer than the usual cataract surgery. So the expectation level is very realistic. And possibility that the patient will have to have a delayed visual recovery should be explained. There should also be a need for compliance of medications, because sometimes the patient might just abruptly try to stop a steroid. So we have to tell him that he has to be very compliant with the medications, requiring frequent follow-ups. And also the patient, in these patients, mostly we end up using a monofocal lens. So they have to be, because, and these patients, when they present to us, can be younger patients because of all these inflammatory cataracts. So when the patient is coming with at a younger age, so his expectation level should be that the eye will no more accommodate. So he might need vision for near vision, glasses for near vision. And there can be early possibility of a posterior capsular opacification, which is one of the most common post-operative complications or post-operative visual rehab problems that we get in these patients. The surgical technique. So the surgical technique remains as per the surgeon's preference, but yet it is said that phacoemulsification, because the anterior chamber maintenance and lesser inflammatory mediators, is more safer. And whenever we are dealing with a case of a uveitic glaucoma, we should not try to combine the surgery, because there's a very high chance of a bleb failure by the inflammatory mediators. Also, if we're dealing with some major retinal problems, then on the first sitting, we can actually leave a patient aphakic to deal with the retinal problems and come back for a secondary IOL implantation in case of need. In case of intermediate uveitis, this often not only improves vision, but this also helps in control of the intraocular inflammation. So thereby this gives an additional importance to the patient, that it can help us resolve the cystoid macular edema by minimizing the inflammatory markers. And at the end of the surgery, we can consider intravitreal injections of triamcinolone, especially whenever we are combining the surgical procedures. But again, it should be made sure that we are not dealing with any steroid responders, and we are not dealing with any eyes of the infectious uveitis. So coming back to the same thing, that we have to classify our uveitis pre-operatively and find out what is the exact cause before we plan on any surgical intervention and the post-operative management for the same. So intraoperatively, the problems that can come around is that the patients that have ankylosing spondylitis, so these are the patients we can actually find out on slit lamp examination only, which will have a problem in placing their chin on the slit lamp. But also we should make sure that they'll also have a problem while lying flat on the operating table. So the posture for the surgery has to be made sure. Also, intraoperatively, we might be dealing with a small pupil with a shallow anterior chamber, and being a posterior synechiae and the peripheral anterior synechiae, along with the pupillary membranes and zonular lysis. So now again, it is important to counsel the patient that most of the cases are being done under topical anesthesias. So because the manipulation of iris can be very discomforting to the patient, so it should be made sure the choice of anesthesia is made accordingly. A scleral or a temporal clear corneal incision is all right to manage, but it should be of adequate length, preventing any iris prolapse for the same. The pupillary enlargement, so because of the limitation of having a poor dilatation in these cases, it is important that we plan for a pupillary enlargement and also plan for a sanicolysis and removal of the pupillary membrane, which will again aid at increasing the size of the pupil intraoperatively. Pupillary expansion can also be done with the help of hooks and pupillary dilators, along with the malunion ring and other options that are available. These are a couple of pictures that they've put on in the article just to make sure that how the pupillary expanders are being used. Also, they have made sure, they mentioned that the capsulorhexia should be quite in the visibility range so that there's no chances of a complication because of the capsulorhexis management during the surgery. So coming to the nuclear management. So in case of nuclear management, they say that the vertical chop is one of the safest procedures to do. Irrigation and aspiration should also be done very cautiously in such cases because of the possibility of the zonular weakness. And the intraocular lens implantation, again, as we just talked about in cases of JIA and chronic uveitis, so this was always considered a contraindication. So it should be made sure that because of the chronic inflammation and the chronic uveitis, the lens is not being cocooned and the problem caused by the lens implantation are not more. And if in case of doubt, we can always postpone the lens implantation for a secondary IOL later. Then for the single piece, a square edge acrylic can be used, and the removal of viscoelastic under the IOL is really important in such cases because again that forms as a nidus of inflammation in these post-operative eyes. Complications can be further subdivided into intraoperative, as I already mentioned, that zonulolysis and also the retained lens, because the pupil diameters are usually smaller. So the probability of having a retained lens particle is a little higher than the usual. So we should make sure that the lens particles are cleared away and there are no remaining nuclear fragments. In early post-operative complications, there's a very high chance of the intraocular pressure spike and recurrence of the uveitis. So this should be seen on post-operative day 1 and with the frequent follow-ups. And the late post-operative complications do include early formation of the posterior capsular opacification and in rare cases, explantation of the IOLs. So concluding, the thing is that now with the higher level of understanding of the uveitic disease, so even now we know that chronic inflammation, even a very low grade, can irreversibly damage the retina and the optic nerve. So we have to have a very careful case selection with a proper timing of the surgery to be planned. And the surgery has to be very meticulous with a minimum induced inflammation with a close monitoring of our post-operative patients. So these all things keeping in mind can come up with good outcomes with a proper management of the uveitic cataracts. Thank you.
Excellent. I think it was a nice summary, Dr. Amrita. You can stop sharing your screen so that we can all discuss this. It's a very interesting topic and I think relevant to all of us because we all have patients who are, crossing over from our side to retina and from the retina side back to us. And so I had a few things in mind which I thought I'll ask you. One was that you mentioned about intermediate uveitis, being improving post cataract surgery. So I was wondering why that happens. That was something which I wasn't
so they've happened to mention that intermediate uveitis, because the inflammation is hardly ever into the anterior chamber. So most of the time, whenever we are trying to make a PCC and trying to do a limited anterior vitrectomy, we are actually clearing up the inflammatory particles from the anterior vitreous phase, thereby and also forming a connection between the anterior and the posterior chamber so that the inflammatory mediators can wash away from the anterior root.
Also, you meant that, if you combine it with a anterior vitrectomy only, then that's what you had mentioned.
Yes,
that,
sir. Yes, sir.
It actually helped more. So was it only mentioned for intermediate uveitis or any other kind of, coexisting, like any other etiology of uveitis as well?
So this has always been mentioned about that that is why we have to classify the type of uveitis that we are dealing with. If we are predominantly dealing with a uveitis that is affecting the anterior chamber and leading to inflammatory mediators, mostly in the anterior chamber, so probably touching the posterior chamber for it in that particular case they have not mentioned into any studies. So they say that if in case we're dealing with the intermediate uveitis, so obviously the inflammatory mediators are very much limited to the posterior chamber and not in the anterior chamber. So that is why we have to classify according to the uveitis we're dealing with, and that is when we can decide the plan of management accordingly.
All right. So maybe we can rope in our retina colleagues and see if they have anything to talk to us about, how to plan which ones. Like we haven't actually done anterior limited antivitrectomy for any of our cataract surgery patients, but if any of our retina side like Saurabh, Dr. Shweta, Dr. Das would like to comment on this.
So well presented, Dr. Amrita, and basically, we have to see if that whenever cataract surgery is done, the uveitis, what is the most important thing is that the uveitis has to be under control, and has been under control for at least a few months, ideally 3 months before we intervene in any cataract, uveitic cataract. And actually, when you mentioned that doing an anterior vitrectomy in cases of uveitic cataract, nowadays a new trend is coming in where it is being used, like a full vitrectomy is being used as a therapeutic modality for treating uveitis. So in cases which are non-responsive, or in which there are a lot of strong agents have been tried, or in which there's a limitation in which the the number of drugs which can be tried, in those cases it can be that the vitrectomy itself is a therapeutic modality, not only a diagnostic but a therapeutic modality. A complete vitrectomy I'm talking about, like a 3-port pars plana vitrectomy. So that is also coming in. So I'm sure that in cases where like you said, that all those are in that retrolenticular space, then likewise there's a space right in front of the disc, which is also believed nowadays after swept source OCT imaging. It has been found that there's that space where all the mediators for posterior uveitis, responsible for posterior uveitis, are sequestered. So once that is removed or that is cleaned out, then the uveitis responds. So I think the vitrectomy as a therapeutic option for uveitis and uveitic cataracts is coming in.
Mm-hmm. So, but I think that's very interesting information, Saurabh. And maybe but we'll have to plan if we have to do a cataract surgery combined with an anterior vitrectomy in certain cases, then we would want to know from you guys when to do that, in case, if at all, because it's going to be challenging. Then after that, since we tend to use a lot of new IOLs now, and it's imperative that we put them in the bag, and we prefer to use single piece lenses, and we don't want to actually place IOLs in the sulcus, because that can lead to more inflammation of the iris. Even if it's a 3-piece lens, there is more possibility of the lens touching the iris when it's not in the bag. So that will have to be thought about. And because if you have disrupted the posterior capsule, whether you should be able to still go ahead in every patient with a in the bag placement. So these things would probably have to be looked at. But I think very interesting, this one particular point. The second thing I thought was about choice of IOLs, because heparin surface modified IOLs were tried out, and after that they tried fluorine surface modified IOLs, and then today I think we end up using more of the hydrophobic acrylic lenses than anything else. In fact, even the this Hoya lens, which is Vivinex, it was supposed to be kind of protecting from some kind of a coating, which material change which prevents PCO and also maybe some inflammation. So but more or less I think hydrophobic lenses in the bag would be preferable rather than that. Now the dilemma is, of course, about these patients, if they are young, as you said, and some of my young patients, we've done quite a few folks heterochromic cyclitis in the last year or so, and many of them were younger patients in their 20s and 30s, and they were wanting to go for a multifocal lens if possible. So it's been a dilemma whether to use a multifocal lens or not. And yes, in a couple of these patients, we have actually who were insisting on possibility of that, we have gone ahead with trifocal lenses, and they've done extremely well to begin with, but we don't know about the long term whether they'll go on to develop CME or epiretinal membranes or other stuff. So any thoughts on this, Saurabh or Dr. Das or Dr. Shweta?
So I think IOLs and their modification, their surface modifications are important, but we must JIA. Not be possible to give essentially have pseudophakia. I mean, like the main thing is that you are clearing out the these cases are very, I mean, the uveitis is very.
Hello.
So in JIA, hello.
Yeah.
Can you hear me? Yeah. So in JIA, like it's not imminent that you have to use an IOL, and because those cases are really very resistant to treatment also, and they need long-term anti-inflammatory therapy. So in those, I'm not sure what modification of the IOL is recommended, but removing the cataract, making the visual axis clear, and also at the same time not having anything. So these eyes in general, they don't tolerate like foreign bodies like IOLs very well. So quite a few of them are left aphakic.
How to decide which ones to leave aphakic and which ones to continue with a pseudophakia, because visual rehabilitation in children is also a very, very important factor which has to be looked at. So any particular group of JIA patients where you might want to kind of leave them aphakic?
So it depends, I mean, the patient is already having band-shaped keratopathy and is on a lot of immunomodulatory therapy, and is having very chronic and at the same time severe uveitis. Those cases may not tolerate IOL well.
Dr. Meenal, do you remember we had treated this young boy with band-shaped keratopathy only about 6 months back, where one eye Dr. Ruchika has done a BSK removal with EDTA, and then we've gone ahead with cataract surgery in both eyes. In fact, I think we put in a toric lens in one eye, second eye, first eye we had just done with the routine. That kid is doing well, but I think he was not that, I mean, he was really bad, but at the time of surgery, it was quite well controlled.
Yes, I remember that case, but I would like to add that his like arthritis is polyarticular arthritis. That means less than 5 joints are affected, and he was very well managed by the rheumatologist, and his eye was definitely quiet when you operated him, and he is doing extremely well. Only thing is he has a CME in one eye.
Left eye. Yeah,
left eye. And right eye, he is 6'9". So he is doing extremely well. So as Dr. Saurabh also was saying, that we should select the case properly. And definitely chronic uveitis patients whose IOP is less and whose inflammation is not controlled even on immunomodulator, we should not put IOL in them. So better to remove the cataract only. But we have to weigh the benefit of IOL, and you have to see how much inflammation is there.
Right.
So,
the other dilemma, Dr. GS, any thoughts, because you deal with a lot of post-uveitic, patients, and all the bad ones end up coming to you for SICS. So would you like to comment on, or do you have any query for Dr. Amrita or for our retina side to, kind of chip in with?
Yes, sir. A few things that I would like to put in for, especially for the uveitic cataracts. One is that, sir, the use of pupil expander has to be, very much on a surgeon's discretion, because some people might use it in a pupil size of, let's say, 5 mm or a 4 mm. But my personal opinion is that in all such uveitic cataracts, we should handle the iris minimally. So if at all possible that you are in that gray area, whether to go for a pupil expander or without a pupil expander. So it's always better not to use a pupil expander unless it is impossible to, operate the cataract. Secondly, sir, at the end of surgery, I prefer giving a subconj dexamethasone, which acts as a depot, because if we are removing the patch after, let's say, 6 to 8 hours, so next morning, you are definitely going to see a lot of inflammation. And during all these surgeries, you have to keep in mind that all the tissues in a chronically inflamed eye are very friable, be it the capsule, be it the iris. So we have to handle them, very gently, and avoid doing any aggressive maneuver like a posterior capsule polishing or trying to make a very small rexes and then putting stress on zonules. It's always good to have a good size rexes.
I completely agree with almost everything that you said. In fact, you pointed out about the rexes being of adequate size, because when synechiae form later on, they will usually form to the edge of the rexes or beyond. So it's always good to have a fairly good size rexes, because most of these will have small pupils. So it's very important that at the time of surgery we end up not having a very small rexes, but in fact try to get a rexes of a fair size, and it really helps to and I agree that pupil expansion, you have to be very careful. So in fact, I would not want to use anything which would expand the pupil unnecessarily large or stretching it really wide, because then the iris trauma will be much more, and obviously post-op inflammation will be much less. Yet I also feel that to get a fairly good size rexes, if one uses maybe iris hooks and doesn't pull them all the way, like you don't really need to have a pupil which is like 8 millimeters or something. Even if you have something which is just about 6 millimeters is usually enough. So a gentle kind of partial this thing with iris hooks can give you enough sized rexes, which I think is good. But if you can manage without the other thing is that if you are operating through a small pupil and you end up touching the phacoprobe on the iris, it's going to cause even more damage or trauma to the iris. So I think it's a mixed bag. You have to use your discretion and your comfort zone as a surgeon, how much of pupil size you are comfortable dealing with and how you will be able to manage it with the least trauma. I think that is the most important thing to decide. And I think a very important point which you Dr. GS was about use of subconjunctival dexamethasone. So here again, I'll ask our retina colleagues to chip in with what may be the best way. Like, what I sometimes do is I give them right after surgery, I tell them to get a shot of intramuscular decatron outside. That also tends to help in keeping, but obviously right in the subconjunctival area is probably going to work the best. And I remember in pediatric cataracts, when we used to operate like 20 years back, we used to, at the end of surgery, we used to usually give them this thing as well. And of course, we used to give subconjunctival dexamethasone and gentamicin for all our cataract surgery patients, when we used to operate and do intracapsulars and extracapsulars. Nowadays, it's not in vogue. Anyway, so here I'll ask our retina team to comment whether, giving intracameral steroid or intravitreal, those, for example, triamcinolone or IVTA, or maybe even those Ozurdex implants, which in PGI they prefer to put with a lot of their patients with bad uveitis in the same sitting. So how can we kind of, use that as a additional modality in some of our cataract surgery patients?
So Ozurdex implant is being used quite frequently in PGI, and for, sometimes at the same sitting also, at the time of cataract surgery. And the only, caveat is that one, we have to rule out infectious uveitis at all costs, because we cannot inject, a steroid implant in an infectious uveitis case. The other thing is that in aphakic eyes, again, Ozurdex is a, kind of little bit of a problem, because sometimes the implant has been shown to come into the anterior chamber. So that those issues must be looked into. Also, in a vitrectomized eye, injecting an Ozurdex is not so straightforward. You can injure the retina while, injecting the Ozurdex. So, some of these issues are there. But yes, dexamethasone is definitely one choice. And the other choice is using a periocular, triamcinolone. But again, at the time of surgery, maybe it's not a very good choice. So that's why Ozurdex is nowadays being preferred over, triamcinolone. Also, IVTA, the release is, uncontrolled. So that is another problem, because you can get IOP spikes, and the duration for which it lasts is also not that long. And whereas in an Ozurdex implant, it's a controlled, sustained release. So that is why it is being preferred over IVTA.
So, we do a fair number of uveitic cataracts at our hospital also, and I'm ending up operating at least 1 or 2 every week with bad synechias and, festoon pupils and everything. And somehow our post-op patients, I've not really seen any of them do really bad with, I'm keeping my fingers crossed and touching wood here, but we see that they do fairly well and they're managed well by our retina side, because we pass them on to you guys. And most of them have done well, except maybe 1 or 2 of them. So like sometimes I wonder whether it's a good idea to actually do, something. Wouldn't it be okay to plan a procedure in case required later on, or is it a good idea? Because I'm always concerned about steroid responders, and Ozurdex intraoperatively can have other issues as well. So I'm just kind of thinking aloud.
Yeah, so it's a concern that, I mean, the steroid response is a concern, but again, these uveitic eyes are, invariably they've been treated with steroids prior, so we know about the steroid response part. And if not a known steroid responder, then also you can get, like, a pressure spike, but most of these cases have been, managed or controlled with topical medications mostly. And rarely in Ozurdex has, like implant removal or trabeculectomy been, required. So most of these cases, are already, it's already known. I mean, they've been treated with steroids. That is a kind of an advantage, that in uveitis cases they were already, checked for steroid response before we, intervene in the form of an implant or anything. So that is one thing. And the other thing is that, again, since it's a sustained controlled release, we don't really see that spike which we see with triamcinolone acetonide. That is what I was alluding to earlier. So it's a controlled and sustained release. It's, it's kind of measured. So we do not see spikes so often, but in our cases, like the cases which we are doing here, like we don't really come across, severe uveitis cases, or even if we come across these, most of them are referred off, like, Behcet's and any severe uveitis, because most of those cases would require very specialized, treatment by a rheumatologist. And a lot of those cases are pediatric. So pediatric rheumatologists, we don't really have the facilities of a good pediatric rheumatologist as yet in our city. So a lot of these cases we refer off. We don't see too many of those, but like once in a while when we get such cases which require a lot of maybe biologicals, which are difficult to manage in a smaller city, then those are the cases which will need specialized treatment. And the cases we are dealing with here, like mostly intermediate uveitis or pan uveitis, with complicated cataracts, those can be managed with mostly with steroids and topical steroids, and preempting or pre-treating them with steroids, before the cataract surgery is done. So that's why we see straightforward outcomes.
Yeah, so I got it, and that point about steroid responders being picked up earlier, anyways, is very valid. The other thing I felt was that Dr. Amrita did mention about patients with JIA kind of a thing, and have making sure that they are absolutely free of every inflammatory cell in the chamber before you proceed. So, which of our uveitis patients should be like any other kind of uveitis where we would be more fussy about ensuring that they are totally free of inflammation before we operate them? Of course, every uveitis should be well controlled, but I caught that point about having occasional flare is still okay, but no cells. So, and also some of our patients do come up with KPs which are still not going away even with good treatment. Some of them are old KPs, and you're not sure whether these are there's any activity which you can pick up in the aqueous or not. So generally, we are always in a doubt whether to kind of go ahead with the cataract surgery or not. We end up transferring them to you guys. And also sometimes we've kind of had patients who were supposed to be operated and started on topical and oral steroids. So which ones to start on oral steroids, which one to maintain just on topical steroids, and which ones to maybe just maintain on who are already controlled? Maybe should we start them, how long before surgery should we start them on NSAIDs, and then which NSAID? This would be of great help to us to plan our patients. And post-op as well, like how many, which ones to put on systemic steroids and which one to continue on topical ones, and for how long, and NSAIDs as well.
So again, I mean, apart from like pukes and JIA, where you can never get the eye inflammation free, like you said that we do not get bothered about flare, because in JIA, even with good control, you may not have a cell free state. So I mean, a flare free state. So but cells, definitely we have to be cautious. So apart from those two conditions, I think in others we can hope for a inflammation-free eye before we intervene with cataract surgery. And also, once we are planning a cataract surgery, it's always good to maybe start them on a systemic steroid, if there's no contraindication prior to surgery, a few days prior to surgery, let's say about 5 days prior to surgery or 3 days prior to surgery, and continue it perioperatively, and also post-operatively, maybe about a week or 2 weeks down the line, so that in general, so this is in general, so that any inflammation induced by the cataract surgery can be countered. And apart from that, I think the usual 6 weeks of topical steroids is good. And in these cases where uveitic cataracts, you may have to increase the frequency of installation of these topical steroids as well, from the normal like 6 times or 4 times that you might be using in a regular cataract surgery. So frequent topical steroids and starting the patient on systemic steroids maybe 3 to 5 days prior to surgery and continuing it for a week to 2 weeks post surgery. Also, you can tailor or customize it depending on the amount of inflammation that you see in these eyes when the cataract has been done. So post operatively following them up and seeing the amount of inflammation you are seeing can guide you as to till when you can continue this hike up of the steroid therapy.
And when should we try and transfer them to the care of the retina side? Like, like we see them post-op day 1, we put them on treatment. We typically would call them on at 2 weeks. Should we be calling them sooner, or at what point should we, kind of ask them to cross over, once things are settled as far as the cataract surgery goes? Because, the critical time for CME and all would start coming in at about 15 to 20 days. And that's the time when maybe, is there any particular protocol we should be following for these patients? Different, like a follow-up protocol, would it be different from our routine cataract patients?
Yeah, so like I said, it has to be more, it has to be more closely monitored, the inflammation. And initially, and because the initial inflammation you are anticipating mostly in the anterior segment, and CME is not so common, so soon after surgery. So so initially it can be easily monitored by the anterior segment specialist on slit lamp, and tailor and the treatment tailored accordingly. And it's only after and definitely you have to follow them up more closely. You can't call the patient after 15 days. You have to see them more often, maybe every 3-4 days initially. Maybe after the first post-op they call them at 3 days, and then gradually increase the follow-up time depending on the the response that you see. And after 2 weeks or so, and then the follow-up can be maintained with the retina specialist to look for any CME which is coming up. So I think in general that would be the protocol.
Wonderful. So I think I've kind of had all my queries answered. If anybody else has any doubts.
In children, can I add on?
Yes, Dr. Mary. Yeah.
Especially in children, like Saurabh sir had said, compliance is very difficult. So if we call them earlier on, and because in children, we have seen quite a few children develop membranes, fine membranes, and if the drops are not being put, because sometimes children it's difficult when they cry, and difficult to open a post-operative eye, and it's difficult for parents. So if it's delayed, then the membranes get thickened, and then it becomes difficult. So as sir had said, it's very important to call them first 2-3 days, and then see how the compliance is and how the reaction is. Then
I completely agree, because some of these children will have a more severe reaction anyway. So in that sense, do you guys suggest that we give them a depot steroid or something? Would that be more this thing at the end of surgery? Should we give them something which will keep the inflammation less? Because we do perform quite a few pediatric cataracts, but most of them, of course, we've been fine with. But occasionally, yes, we will have. Dr. Meenal, any thoughts on that?
Sir, giving a depot steroid, I'm not sure, because there will be a chance of increase in IOP. And again, in children, we won't be able to measure the IOP because they are uncooperative. So preoperative counseling is the most important thing. Like we have to educate parents that they have to put the drops properly, then only the inflammation is going to go down. And that we usually do to each and every pediatric cataract also. We tell them the uh, necessity of using drops, necessity of glasses, amblyopia treatment, that we tell before the surgery. And accordingly, they are prepared for that. So giving steroid, there will be high chances of increasing the IOP.
Perfect. That sounds good. So I think that's nice. And if anybody else has any questions to discuss or any thoughts or any queries, it'd be nice to discuss now, because then we can close the meeting in a couple of minutes.
Sir, what about doing a PI, sir?
Intraoperatively for these patients. So, you're right that there are some patients whom we've burnt our fingers with, where they've gone on to develop iris Bombay post-operatively with the inflammation, kind of coming back. I do remember at least 2-3 of my patients over the last few years where we ended up then doing a YAG iridotomy to release the iris Bombay. So I think, but I don't know whether as a routine for all these patients, whether we should be doing a PI or, maybe a laser PI if things start, going in that direction, because there are only very few of them. But that's open to, discussion. What are your thoughts, Dr. Das, on this?
So many of the patients, they develop very bad synechia post-operatively. The iris gets stuck to the IOL or axis nerve. Then it becomes very difficult. And again, we have to go to a PI, and PI induces a little bit of bleed. Bleed will again induce inflammation. So I just wanted to know whether it should be done preoperatively or intraoperatively.
Especially in children, it would be better to do, because later on to do a PI, laser PI also will be difficult. And because the iris is already inflamed, so it will be a difficult thing. So if we are taking up a child under GA and we are doing a cataract surgery, if we can do a PI, surgical PI at the same time, it will be very helpful.
So I think that's a good idea. And in fact, nowadays doing a PI is so easy on table with a cutter. It just makes a perfectly sized PI, which is not very big, and visually also it may not be compromising, and yet it is enough. But in these patients, doing a small PI definitely is not a good idea, because it tends to close down very easily. In fact, I remember some of my patients where I was managing them for iris Bombay post cataract surgery. Like few months later, they went on to develop iris Bombay. I used to do multiple LPIs on the slit lamp, and sometimes they would come back in a couple of months with these PIs closing up and maybe 1 or 2 pockets forming again, and then doing another small PI. So these things I've been trying over the years, and yes, they worked very well. But I think doing a surgical PI is definitely a good option where you are expecting a very severe situation like that, and selectively doing it for those patients would definitely be a good idea. And maybe even doing 2 small PIs in 2 different areas may be nice, like maybe a supranasal and a supratemporal one. Definitely good point, Dr. Das.
Secondly, sir, when you dissect out that seclusive people, I think recently you have operated 2 or 3 cases, you remember, sir. Then
I'm sorry, I didn't catch the last part, Dr. Das.
So recently, I think you have operated, 2 or 3 very bad seclusive people here. They are doing quite well, actually. And hello.
I think I'm losing network off and on, I think. So,
right.
but yes, we've recently operated a few patients, and
very bad seclusive surgeons. When you dissect out the iris, do you feel any bleed or something, that some phacodonosis?
So luckily, we don't actually get bleeds, but we do have to have sometimes, there are pupillary membranes which need to be peeled. And in fact, sometimes I've actually done a kind of a rhexis of that membrane. And in some cases, in fact, one I did only about a month back. I had to really use the scissors and all to make sure that, this was tackled correctly. And it has to be very patiently done. And, doing it under viscoat also helps a lot, because it kind of keeps the chamber, and the iris very much in place. And you have to do it very patiently And also sometimes pulling on the iris is not a good idea, because you may end up creating a dialysis, and sometimes the synechias are so bad. Yes, it can occasionally bleed as well if you are rough with the tissues, but wherever the adhesions are really bad, it's always better to just go with the micro scissors and release it. But you have to be careful that you don't damage the capsule. So it is like a couple of patients that were really, really bad, which I did. In fact, maybe in one of the future meetings, I can show some videos of all the uveitic cataracts we've done, and that will be nice to kind of discuss with everybody. But I agree that sometimes they are very, very challenging, and one has to be careful and ensure that you can manage them well.
Right.
So that's nice, I think, and we've had a very fruitful. I think we've all learned how we can deal with our uveitic patients better. But anybody else with any thoughts before we close?
One last question, sir. One last question.
Yeah.
For CME, to prevent CME, is there anything else we should do other than the regular things which we give?
So for CME, I think traditionally flurbiprofen was the preferred drug to prevent CME, and it still is being used by uveitis specialists for prevention of CME. But I think nepafenac is also being used in the post-operative regimen also, I've seen. So I think these NSAIDs, apart from the topical steroids and the systemic steroid cover, the NSAIDs can be used for maybe 2-3 months to prevent whatever prevention can be done for preventing CME. And also, as I said, that the inflammatory activity has to be under control before the cataract surgery is planned, and preferably for about 3 months. So if we kind of take care of all this, I think CME can be prevented.
Great, thanks for those inputs, Dr. Saurabh.
So
I think
one last question. So in that young boy whom we operated for BSK removal and cataract for because of JIA, he has persistent CME in the left eye, which was actually operated first. Right eye, which was operated later, is doing quite well. And I've tried prednisolone and then dexamethasone eye drops, but for some reason there hasn't been any remarkable improvement. So, sir, can we consider Ozurdex implant in that case?
So what is the pathology? I mean, what's the disease process that we are looking at? I mean, which is causing the uveitic cataract in that case?
So he had TB synovitis in his knee, and he was given ATT,
Okay.
although they couldn't isolate any MTB on Gene Expert. For some reason, he was given ATT for 9 months. Then he's RA factor negative, HLA B27 negative, but he's under the treatment of Dr. Kamal Bhatt, and for all practical purposes, they're treating him as JIA only. So,
But you said that there's a tubercular process also going on in the body.
previously, before going to the rheumatologist, they had done like a tap and all from the synovial fluid and all, but they couldn't isolate MTB. For some reason, he was still put on ATT.
Okay. So, I mean, if there's no infectious process going on in the eye, then we can consider Ozurdex. But if
Right.
we are not able to rule that out, then again, like I said before, in infectious uveitis, you would kind of avoid. But if there's no obvious sign of infection or infectious uveitis, then Ozurdex can be an option in that case.
Right. Okay, so.
In fact, I agree, Dr. Shweta, because I've been very concerned about that guy, because the first eye was the bad eye, where
Yes, sir.
he had, in fact, we had operated him in 2020, I think,
Feb.
somewhere was lockdown going on.
Yes.
No, the first time we did in 2020, I think. Dr. Ruchika had first done the BSK, clearance, and then I had gone on to do the cataract, and then the second eye he was lost to follow up for a couple of months, and then he came and did his second eye somewhere in summer of 2021. I'm not sure. And the first time which we had done, which had more severe, uveitis with band-shaped keratopathy and all, the second one didn't have band-shaped keratopathy. That one
Yes, sir.
persistent CME, as you correctly
Yes, sir.
and
Yes,
I've
sir.
been a little concerned about his CME and whether how to, make
Yes,
him,
sir.
settle down. So maybe
Yes,
next
sir.
time he comes again, you guys can brainstorm and
Yes,
decide
sir.
what more we can do. So
Yes, sir.
very, you good point you made. Thank
Yes,
you.
sir. Yes, sir. Yes, sir.
So I think we've had a great session, and if everybody must be, looking forward to dinner now, and maybe, we can continue these discussions further another day, unless there's something very important which anybody would like to comment upon. And then thank you so much, Dr. Amrita, for a very nice talk, and for all of you for a wonderful discussion, and hoping to keep these sessions alive. And I'm looking forward to ideas from everyone on what else we can do in the future meetings. I think this Friday we can skip our own class. Maybe I have in fact, I wanted to invite all of you. There is a, meeting of the Trivandrum Club, which where I'm giving a half an hour, 45 minutes lecture on ICLs and phakic lenses and the pearls and pitfalls and everything. And if you guys would like to join, I'll forward you the link if any of you are keen to, join that maybe. And if you guys want to carry on with another meeting, we can always have all of you do a retina meeting if you want. And, I can kind of skip that one. So, Saurav, we can maybe decide tomorrow, right?
Yeah, actually, I have a Novartis meeting on Friday evening. So,
Okay, so I think we have two meetings to kind of possibly attend. I'll forward the link. I'm sure they will not mind if all our doctors or whoever wants to join and could join. So let's take a holiday from our own meetings on Friday and attend these if we have to, and then we can always come back. And also, if everybody could put in inputs about preferred time for these meetings that we can do. The other option is to do it in the morning, maybe around 8:30. Only thing is that those people who have to come to the hospital at that time, like 8:30, 9 o'clock, then they would have to attend the meeting from the hospital. Otherwise, that can get delayed, and we don't want to delay the OPD starting in the morning beyond like 9:30. So if that's a better time for all of us, let's put it on the group, and we can plan to change the time as well. So I think we'll close now if everything's good.
Yeah.
Yes.
Thank you, everyone. Good night and have a great, great evening.
Thank you. Good night.
Thank
Good
you.
night. Okay.
Thank you, sir.
Bye.